You have been invited to address this topic in this forum, and really quite a great program by you guys at head office and by Netcare for setting up this program for people to be able to share experience and their insights into various topics within COVID. So should be interesting. So the cardiac COVID patient consists of two types of patients. The first, and I think most importantly not to forget about, is the non-COVID patient in COVID times. I think that we often in the past number of weeks get so fixated on COVID and the numbers with COVID and the amount of patients that are coming through the door with COVID that sometimes we are challenged to remember that there's a large cohort of patients who do not have COVID, yet who have chronic illnesses. In the case of cardiac disease, these patients often don't seek help. And if they do seek help, they seek help at much later stages. And when they present with extreme presentations, extreme decompensation. Often they're too worried to seek help and sadly die at home. They're not following up for review of chronic conditions. Therefore, when one wants to up-titrate their medication to optimal doses, this is not being done. And so suboptimal titration is occurring and the patients aren't hitting target doses of medication. Problematic repeat scripts, although that's more easily done over the web. And then defaulting on baseline monitoring, such as INR for patients who are on warfarin. I had a phone call the other day from somebody who called and said that their mother had a very low heart rate and a very high blood pressure, but I said, well, let them come past the rooms. And she says, oh, no, we can't come to the hospital because, there's COVID there, and you try and make sense of that. But there's a whole cohort of patients who have ongoing cardiac issues or chronic issues who need to still be managed. And I thought just to give a shout out to that topic for consideration. When we talk about cardiac and COVID, so often patients will call and they'll say, well, am I at risk for COVID because I have X, Y, or Z condition? And sometimes you hear it in medical circles as well, where we're all equally at risk for COVID. COVID exists for everybody as a risk, but the risk of contracting severe COVID and requiring hospitalization, ICU admission, more invasive management, and overall poorer outcomes is associated with a set of fairly defined risk factors. And as COVID has moved on, these risk factors have become more defined. However, strangely enough, not all patients with risk factors end up with severe disease and poorer outcomes just because they have these diseases. So the real question is, how does one ascertain or try and risk stratify who's likely to deteriorate or who is deteriorating, and therefore allow for an earlier intervention and early in terms of treatment or referral to more specialized care where required. So I kind of thought about it perhaps to say the key therefore is to know what you're looking for. Once we know what we're looking for, well, then we can look for it and try and get on the bandwagon early to manage it or to know that it's coming at us. And to know what to do about it once you've identified the problem. What are you going to do about this problem? To know when to call for assistance, and we'll come to that a bit later. And to know that no one knows enough about COVID to have all the answers. And I think that this cartoon just says it all in many ways. But the underlying message here for me is that if you think you've got COVID covered, it's going to rebound at you very quickly, and it will come with a surprise before you know what's hit you. So you've got to treat it with respect, but nobody has all the answers. So when looking at the risk factors for severe COVID, and these show a large overlap with those for severe cardiac disease. Specifically, we're talking about age, older age, higher risk of COVID, poorer outcomes or severe disease. As with cardiac disease, you get cardiac disease as you get older. Male propensity towards having a poorer outcome or a more severe COVID has been shown in a fair number of observational studies. Hypertension is an association. Diabetes, definitely, and in the 100 or so cardiac COVID cases that I've been involved with, there's definitely a propensity towards a more stormy course in patients definitively with hypertension, with diabetes and with chronic kidney disease. And obesity is a real comorbidity that needs to be taken very seriously on multiple levels for poorer outcomes, not just because the patients seem sometimes to do far worse, but also because they come with a host of other complications once in the ICU that come into play with COVID. And then established cardiac disease is obviously a further risk factor. So without going into too much detail, I know we have quite a diverse viewing, people from varying different sectors within healthcare. So without going into too much detail, I thought I'd just kind of touch on the mechanisms in which COVID affects the cardiovascular system. So to be honest, as with most things in COVID, this hasn't been fully elucidated, and there's likely multifactorial causes for the way in which the cardiovascular system is affected. But to split them into two main groups, you have a direct myocardial damage. So we know about this because on PCR genetic testing of cardiac tissue, in some cases, they have found viral particles which would suggest and support the notion that there is a direct myocardial toxicity whereby the virus goes into the cardiac cell and causes damage within the cardiac cell. And it gets into this cardiac cell, into this cardiac myocyte through the angiotensin converting enzyme 2 receptor co-binding in order to be able to get in. The second way in which COVID affects the cardiac system is through indirect myocardial damage. And this would seem to be more wide-reaching, and I think in the majority of cases is the more to blame damage or a route by which the cardiac system gets involved or is damaged with in COVID. So what happens over here is that there's the virus in some patients causes a hyperinflammatory response, as we know, with a huge cytokine release and known as a cytokine storm. And this may lead to vascular damage and vascular inflammation and to myocyte damage and inflammation. In addition, it can cause plaque instability. So patients who have a propensity towards coronary artery disease, or they have underlying coronary artery disease, but it's been undisturbed or is stable. I don't ever think of coronary artery disease as stable at any point in time, because if you have coronary artery disease, then technically it's not stable. But so if it's a more chronic coronary artery disease without flaring up, the plaque in the presence of a viral infection, we know this from influenza, and it certainly plays a role, as we'll see a bit later, when it comes to COVID. Plaque instability and rupture of that vulnerable plaque within the coronary artery can be precipitated through the viral infection and through the whole milieu that gets created within sepsis and within the inflammation. So myocardial inflammation is another way in which the heart gets damaged indirectly. So once again, this entire septic and hyperinflammatory and hyperresponsive milieu that exists within the body, once again, damages the actual myocardium as well. A hypercoagulable state, we know that in COVID, there's a huge hypercoagulability, and strange enough, these patients often seem to have, despite being hypercoagulable, they have a bleeding that occurs at the same time, and it's fairly challenging to manage these patients because you want to manage their hypercoagulability at the same time they're dropping the hemoglobin because they're bleeding, and that can also play huge stress and strain role on the heart. And then direct myocardial suppression through a variety of mechanisms. So this is where, although the actual myocytes themselves are not dying or inflamed, there's this entire inotropic or chronotropic or suppression within the cardiac system and within the myocardium and within the heart, the hemodynamics within the heart, and things that causes us sepsis, DIC, and any other form that may mediate. And obviously these are just a few of the mechanisms by which one can get indirect damage, but these are the ones that seem to be at play in a fair number of cases. So in my mind, in terms of approaching a cardiac patient who has COVID, I tend to try and break these down into 4 separate groups. So my group 1 that I think about is COVID, a patient that has COVID and has an underlying established cardiac condition, such as a cardiomyopathy. This may be any form of cardiomyopathy. Cardiomyopathy is where the actual heart muscle does not function adequately. Either it does not pump adequately or doesn't rest adequately. So you can have lack of pumping activity with a normally sized heart. You can have lack of pumping activity with a enlarged heart, essentially with a reduced ejection fraction. These patients are more prone to have more challenges when hitting COVID with sepsis or with hyperinflammatory response, because they lack the ability to be able to compensate as best as anyone who has a normal heart. Arrhythmias, there's increased risk for certain types of arrhythmias. So advanced right ventricular arrhythmic cardiomyopathy, these type of patients have an increased risk. But patients who have arrhythmias are at risk for a more stormy or more challenging course when it comes to COVID, because number 1, often they're on medication for their arrhythmias, and these medications have to be adjusted because of other concomitant factors, low blood pressures. All these arrhythmias are precipitated further by medications that we're giving, such as inotropes in patients who require them. So the arrhythmias become quite challenging. In addition, some of the medications that initially were being used when we were using hydroxychloroquine, and to some extent, I guess, is some of the medications we are using, such as Zithromax, do play a role in terms of interacting with some of the drugs that we give for the arrhythmias. So you need to be sure that you're considering the drugs that patients taking in terms for the antiarrhythmia, and then once again giving added drugs to these patients, and either precipitating their arrhythmias, inhibiting the medications they are taking. So to keep an eye on the drug-drug interactions. Coronary disease, as mentioned previously. So the coronary disease, patients who have established coronary disease, they're on medications often for aspirin or Plavix or Brilinta or any of the others. And once again, in setting of hypercoagulable state and giving further anticoagulation in terms of Clexane or Arixtra or whatever it is that we're giving these patients, and in addition to that, giving steroids, these patients have a propensity towards bleeding. And we are seeing a number of patients who are presenting with upper GI bleeds, and strangely enough, psoas bleeds, bleeding to the psoas, which is just strange. And so these need to be thought of very carefully in terms of stopping medications that are with fresh stents in or fresh coronary disease. These can be fairly tricky decisions to be made. And then lastly, patients who have undealt with underlying coronary disease, once again, are at risk for either plaque destabilization, or once you start to put these hearts under stress and increase the demand of flow down those coronary arteries, you stand the chance of having a supply-demand mismatch, which is a concept that we'll come to slightly later. In terms of valve disease, underlying valve disease, either untreated, undiagnosed, or untreated, or with prosthetic valves, there's an increased risk for deterioration when there are fixed stenotic lesions. So a fixed aortic stenosis, a fixed mitral stenosis in patients who are tachycardic, and patients who have different requirements and shifts in hemodynamics and are on inotropes, can be very, very tricky patients to manage. Patients who have prosthetic valves in, once again, they need to be monitored for their INR, and COVID can throw INRs out horrifically, with patients coming in who have been stable on warfarin for years and now coming in with INRs greater than 10, and that's their only presentation of COVID sometimes. I'm not sure if there's perhaps a drug-drug interaction with the zinc and the vitamin C, but those may be involved as well. Then many other, sorry, just let me close this down over here. Chris, can I relaunch?
Yes, yeah, you can close it. Sorry, I was just ending it.
Okay, so can I close there? Okay, end poll, right, there we go. I was saying earlier, we're very, very unused to this Zoom thing because we kind of see our patients face to face. So when these things pop up, not quite sure what's going on, but here we go. So there are many other factors that make a cardiac patient fairly challenging in the ICU setting. And I know there has been another topic on ICU, but sepsis and inotrope use are really challenging in sick cardiac patients. Transplant patients, as you may or may not know, there's a cardiac transplant program in a number of hospitals around the country, one of which is Mill Park Hospital. And to date, we've had 2 cardiac transplant patients who have had COVID. The one was able to remain at home and was symptomatic, but didn't require any hospitalization. The second required hospitalization more for lethargy and but not hypoxic and not in any form of cardiac failure. And both of them did surprisingly well, given our worry about immunosuppression. But I mean, this is totally unfounded as a statement, but perhaps the fact that they're on immunosuppression medication may help them in terms of not progressing to a cytokine storm, but that's really, really not supported in any way, shape or form. It's just a thought to consider, but there's really nothing out there about it. And then congenital heart disease is another segment of patients, or another category of patients who really can pose a high risk when it comes to COVID, and can pose a number of challenges. So that's the first group that I'd say that kind of we split them into 4 groups. The first group was a patient who comes in with COVID who has established cardiac disease. I then think about a second group of patients who have COVID with new onset cardiac findings. So now you get asked to consult on the patient because the patient has a murmur, or because the patient has an arrhythmia, or because the patient has a change in ECG. Now, the question one needs to ask themselves is COVID the cause of the finding, or is this finding that one's found happens to be found now because the patient's in hospital and it's always been there, or it's been a problem along the way, or not such a problem along the way, but it's a new finding now. And that's sometimes fairly difficult to be able to tease out. Often one needs to dig back into previous histories and try and speak to other practitioners who have been involved with the patient's care over time, or try and get a previous ECG if there's an abnormality, or speak to family, especially when patients are on ventilators, to try and ascertain what exactly has gone on. As an example, there was a patient who was asked to do a cardiac consult with COVID in an ICU. The patient had a very, very tight aortic stenosis, a narrowing of the aortic valve, requiring intervention. In fact, there's been 2 of them who have presented like that. And so that's not there because of COVID, but it's a finding that's been found at the time of COVID. It's opportunistic, if you like. And when thinking about that in a more broad sense, not everything needs to be fixed at the time when the patient's there for COVID. Sometimes just knowing about that and then allowing the patient to get through the COVID, settle down, and bring the patient back at a later stage to be able to further work up and deal with that is the far wiser option to choose, because COVID, as I say, throws curveballs which one wouldn't have otherwise expected. Group 3 is a category of patients who I think about as COVID associated, but with no major impact and likely to resolve with COVID recovery. I'll show you an ECG of a patient like this shortly, but this is a fairly large number of patients who one gets consulted on or picks up an abnormality on the ECG, and you're able just to sit tight and observe it or watch it, or we'll come to troponins now. monitor those things and not have to do anything specific about it other than watching it and knowing that it's there, rather than acting on it in an invasive way or with further workup, or tide the patient over. It will likely resolve and then move on. And if it's not resolving, then obviously follow up at a later stage. And then group number 4 is a COVID bystander. So I'll show a couple of cases a bit later. This is my last case, just to show about a COVID bystander. But as an example, there's a patient who's asked to consult on, who came through with a obstructive jaundice for the surgeons to see, had been worked up at another hospital, and was COVID positive when he came across to Mill Park, and now is being tied over with a temporizing procedure prior to having a Whipple's procedure. So the COVID is a bystander. He's never been hypoxic. He's never required anything for that. But even when you think COVID is a bystander, sometimes there's something else cooking, and we'll see that in a couple of cases. So signs of cardiac involvement, history and clinical findings of cardiac disease or dysfunction. That's a general approach to your clinical history and examination. The next section would be that of raised cardiac markers indicating myocardial ischemia or injury, and we're going to spend a couple of slides on that coming up now. ECG abnormalities coming up now, all sorts, and I've just thrown in some examples of some of the cases that I've been asked to consult on and manage. And then imaging abnormality, and just to say that echocardiography can be a real challenge in determining definitive etiology in these patients. They have lots of drugs on board. They have lots of, it's often they'll be ventilated on APRV modes, which or high peak modes, which don't allow for adequate penetration of the echo probe through to get great imaging. So there's any number of reasons why it can be challenging, but as will be seen, it is a very useful modality to be used. So let's talk about troponin. So moving back one slide, this over here was, so with history and examination, we're not going to talk too much about. Raised cardiac markers we're going to talk about, then we're going to go through some ECGs, then we're going to go through some imaging and cases, and that's where we're at. So troponin. So the data when it comes to hard, good, prospective data is very scarce in terms of COVID. It's a new disease, and a lot of people have written kind of case studies or their experience, and then others have gone and reviewed the case studies or the cohort data, and that contributes to our understanding and our knowledge of who's at risk and what they're likely to get and what to do about it. But there's no hard data. So I've pulled some data over here from a couple of studies that have been published in good journals. So the concept over here is that increased levels of highly sensitive troponin, and if you don't have highly sensitive troponin, then troponin in general, correlate with disease severity and mortality. So even if one takes other factors out of the picture independently, and a raised troponin puts patients at risk for a more stormy course and for morbidity and mortality. Not just that, but the pattern in the rise. So a rapid rise also has a prognostic indication. Now, if you read the next one, is that patients who had a higher level, and this level continued to rise up to a point in death, and in this study it was 18.5 days was the average in that cohort to the time of death, while troponins were, for survivors, remained just stable. So those patients that had that upward swing in their troponins that continued to rise generally did more poorly than the patients who had a increase in their troponin and it kind of stayed level. And once these troponins do go up, one needs to start to think about managing those troponins, and we'll talk about that a bit later. So as mentioned before, cardiac injury is an independent risk factor for in-hospital mortality. And then the last point basically says that if a patient came into hospital and had elevated troponin, their rate of death was 37.5%, whereas if they had raised troponin and underlying cardiac disease when they came in, they almost doubled their rate to almost a 70% chance of having a poorer outcome. So just to touch on something, this is kind of not specific to COVID, but it is a general concept within cardiology that then plays out in COVID. So causes for raised troponins, is beyond ischemia. So myocardial injury, if you look at the top left column over here, and I don't know if you can see when I move my mouse. So myocardial injury related to myocardial ischemia, where one has atherosclerotic plaque disruption. So this is a heart attack, where there's a clot that's sitting in the coronary artery that then disrupts and causes a heart attack. We'll come to slightly more defined way of categorizing these. Then the next reason for having, so that's ischemia. Then the next reason for having ischemia or lack of blood supply to the heart muscle is from any of these other causes, and we'll come into slightly more detail with these in the following two slides. But any of these from a coronary artery spasm, whether spasm within or in the coronary artery that supplies the blood to the heart, or the very, very small blood vessels that distribute the blood beyond the coronary arteries. When we look at later we'll look at an angiogram or two, we're only looking at the epicardial vessels. Those vessels then get smaller and smaller and smaller and smaller and smaller and supply all the areas of the heart. Now, if there's dysfunction in those small blood vessels, which we can't see on angiogram, that can also cause a raise in troponins. There's embolism to the coronary artery, there's dissection, and any number of hypotension and shock are causes. Severe anemia. Okay, so those are all causes. Then sustained tachyarrhythmia, which we often see. These patients are often very tachycardic for a very prolonged period of time, and that in itself can cause a rise in the troponin from ischemia, although there's no blockage to the actual flow of blood within the epicardial vessels. Then causes of myocardial injury. So one can get raised troponins from cardiac injury, myocardial injury, independently of ischemia. So heart failure can cause a very big, dilated, dysfunctional heart, can cause hugely elevated tropes up in the thousands. Cardiomyopathy, Takotsubo, which is a stress cardiomyopathy, defibrillator shocks, cardiac contusion, as we know. And then lastly, and I think it's important when it comes to the COVID patients, is systemic conditions. So sepsis itself causes a rise in troponins. Chronic kidney disease causes a rise in troponins. Stroke, subarachnoid hemorrhage, any of these that you see here and more can cause a rise in troponins. So troponin is an important factor to look at, not just because it tells you something about the coronary arteries, and not every raised trope, as we know, is indicative of a heart attack. Which is why one needs to have the more defined definition of a heart attack. But it tells you that there's something going on with the heart. If it's not on the left side where we're talking about ischemia, it's on the right side where we're talking about injury. So a raised troponin tells you there's heart involvement in some way. This is also from the European Society of Cardiology, which is the universal definition of myocardial injury and myocardial infarction. So as you see over here, there's 5 subtypes of myocardial infarction. 1, 2, and 3 is 1 and 2 are the key ones to think about. And one needs to have a rise and fall of a troponin level beyond the 99th percentile, and then any of these other findings which are listed over here in terms of typical symptoms, ECG changes, pathological Q waves. On echo, you see abnormal heart movement or abnormal wall motion. And then you may be able to find coronary thrombus at angiography, or in the case of patients who have passed on, then at autopsy. So this is just an illustration of a myocardial type 1, once again, from the European Society of Cardiology. You can see on the top over here, this is a plaque rupture or erosion with a occlusive vessel. So you've got a plaque sitting over here at the bottom that then has ruptured there, and this has caused platelet aggregation, this total and absolute lack of blood flow down that vessel, this patient is going to present with a STEMI. Then when you get this plaque rupture or erosion at the bottom with non-occlusive thrombus, so there's still blood flow through here, this patient's got chest pain because there's a lack of blood supply distal to this occlusion, yet there is some blood flow there. This patient is more likely to present with a non-STEMI, non-ST elevation MI. So that's myocardial infarction type 1. Myocardial infarction type 2 is where you have a mismatch between the supply of blood versus the demand for the blood. So in the top picture over there, if you have, once again, also from the ESC, the European Society of Cardiology, the fourth universal definition of myocardial infarction. So atherosclerotic and oxygen. So in the top one, what you have is you have a narrowed vessel, and when the patient's well, or when the patient's not active, the patient's able to supply the distal to that very well. Yet put the patient under a stressful situation, either on a treadmill potentially, or when they exercise, or when they're sick, they're going to have a problem. Once again, if they have vasospasm, very spastic vessels that are very troublesome, and as they spasm, they get severe pain. There can be dissection, there can be supply-demand mismatch alone. In a patient who has a low hemoglobin, you're going to be dealing with a oxygen supply-demand imbalance, and there's no occlusion to that vessel at all, yet the patient's infarcting. They've got typical type chest pain. They may have some form of ECG changes or may not. They're going to have a raised troponin. So they have typical type chest pain and they have a raised troponin, well, then you've already got two criteria, and you fulfill the criteria, myocardial infarction. So that's just some concepts to think about in terms of myocardial infarction versus myocardial damage. And this is a further, once again, from the same website, that starts to give, and you can go through this at some stage, more broken down explanations of those pictures that we've just seen, and the way in which the imbalance occurs. So we know that tropes are very important, and I think that in reading the literature, it was suggested, and this is what I do for my patients that I'm called in on, is I ask for a set of baseline troponins. Often the troponin will be raised, and when I say raised, I say with the lab that we're using, or the labs that we're using, with a highly sensitive troponin, I kind of think 150, 180, once it starts to, or 200 maybe if the patient's also got renal dysfunction, chronic kidney disease, it's septic, etc. Maybe I'll allow a little bit more of a leeway, but I know that there's damage going on. And then once I have an indication of myocardial involvement, it firstly says to me, do serial tropes, and there's value in that, and I'll show you why in some cases later. But also what it means to me is that even if the patient seems to be relatively well and is a ward patient, not an ICU patient, I would, and once again, the data is not definitively there in any studies, I would suggest in my patients, I start a more, in a higher level of pharmacological care. So I will suggest to the team, I'm incredibly privileged to always work as part of a team. You know, they never let cardiologists do things on their own. They always want to supervise. So now I'm very privileged to always work as part of a team. So I have a good support from physicians, and to discuss with the physician and then maybe add on steroids for that patient. I believe in colchicine, not because I have any solid evidence for it, but it makes sense to me, and it's not causing adverse side effects in these patients, so I am using it. So that I kind of step up my monitoring of that patient, and I do serial tropes, and I also step up the type of medical care or the pharmaceuticals that they're going to be getting. Moving on to some other suggested markers, pro-BNP. Once again, this pro-BNP can be up for any number of reasons, but A higher level is associated with poorer outcomes. What exactly that level is, there's been one study that suggests 88.4 picograms was the cutoff, and beyond that, the outcomes were poorer. I have less of a feel for how, in my own practice, for how this works. I don't like repeating these tests too often from a cost perspective, so I use tropes and not as much the proBNP, but I do tend in sicker patients to get a baseline proBNP, so I know where that patient's going when should they go off at a later stage. Or a high risk patient, I'll take a baseline proBNP, not because at that point in time it gives me anything definitive to work with, but because it gives me a baseline to work off of down the line should the patient decompensate, and often it's been quite helpful. And then CRP and IL-6 elevation is an indication of cytokine storm. And we do know definitively that once that the heart is involved, once the cytokine storm kicks, there's generally cardiac involvement to a greater or less extent. Okay, so back to our kind of approach. We spoke about clinical history and examination. We spoke about cardiac markers, and this is kind of trying to predict, so we know who to predict the problem is going to come in, because we know of our risk factors of who's likely to have a more challenging course in the hospital and a poorer outcome in terms of morbidity and mortality. We know that there are some things from the cardiac side that we can monitor at baseline and as a trend along the way in order to kind of judge when patients are dropping off, deteriorating, or likely to deteriorate. So that patient is climbing, you need to do something early and not wait until the crisis is hit. And then we said what to do. So we've spoken a little bit about some of the escalation of drugs and thoughts around that. And then some of the complications or some of the presentations that happen. So one of the presentations that patients with COVID present with is arrhythmias, and there's any number of arrhythmias. I've just put down some of them here, and I'm going to show some examples from some of the patients that I've had in the wards. So atrial and ventricular ectopy is very common. We all have them. These patients are on monitors often, and they're being picked up, and so that they can be normal. But just once again, go check electrolytes for all of the arrhythmias. Check electrolytes, check thyroid, so TSH, CMP. And just kind of get a baseline of those. Often we find magnesium, for some reason, in my experience with the patients I've seen, magnesium tends to be quite low. I'm not sure why, but replacing magnesium really makes a big difference. So I tend to keep these patients at a higher level of magnesium. And also, once they've got arrhythmias, I tend to try and keep them at a higher level of potassium. So when a higher level of potassium, I'm saying around 4.5 to 5, I'd like to give them that. And then the magnesium, you need to replace magnesium. If you've got a very low potassium, you will need to replace magnesium before you can get your potassium up. If you don't know that previously, just remember it. It will save you a lot of time, and that's because of the mechanism at the level of the kidney where they are co-transporters. So always replace your magnesium if your potassium's low and your magnesium's low. So I replace both of them and I keep them at higher levels. So sinus bradycardia, I'm going to show you an example of one of the patients with sinus bradycardia. And it's a fairly common finding, but it gets people a little bit stressed out, and we'll talk about that in a moment. Sinus tachycardia, that's probably half the time for us treating the patient and for the patient too. It's fairly stressful at times. SVT, so supraventricular tachycardia, very common. Atrial flutter, atrial fibrillation, I've got some examples coming up. Ventricular tachycardia also occurs, most of the time non-sustained, which means that it just happens for kind of 5 to 10 seconds, but then resolves on its own. Ischemic changes may or may not occur depending on what your presentation is. Sometimes the only presentation that your COVID patient has is an MI, and they have ischemic changes, and you swab them and they're positive. Non-ischemic T-wave abnormalities we'll show now, and then QTC. So our QT interval is a key marker to keep an eye on when it comes to COVID, especially with the type of drugs that are used. And I've put some parameters for normal and abnormal there, for male and female. So some examples and some cases. So here we go with a 62-year-old female who was chest pain free. The tropes were 180 and she was hemodynamically stable. And if you count that out, that rate is sitting at around 45 or so, which is concerning because she's quite bradycardic, yet she's chest pain free. Sorry, the second issue over here is that if you look at lead ABL over here, and you look at lead 1 over here, you'll see that they're very deep inverted T waves, and those T waves are abnormally inverted. They shouldn't be like that. So there was always concern for ischemia here, yet chest pain free. And so a couple of other things just to mention here is that when looking at a bradycardic ECG, so is the patient symptomatic? No, they're not. She was hemodynamically stable. She had no chest pain. She had no neurological dysfunction. She had COVID. And we do know that with COVID, sometimes with the viral, with the time when the patients are heavily virally shedding or virally loaded, they can brady, and it's not just in COVID, it's been described in other viral infections as well. But I know on this ECG that this is a sinus ECG, firstly because there's a P wave before every QRS, and I know that the P wave is upright in lead 2 and inverted in AVR, and so I know that there are other factors to take into consideration, but I know this coming from the sinus node. So this is a sinus bradycardia in a patient who is hemodynamically stable. The tropes sat out at around 180, and then as she got better, started to come down. I've left her alone. She's going to come and see me in around 6 weeks, and we'll see what her ECG looks like. Put on a treadmill, see if she's got any ischemia, because those leads, the high lateral leads, are concerning for ischemia. This is just I'm looking at the time over here, and I'm going to move ahead quite quickly. This is just an approach to tachycardia. So you've got regular and irregular, and you've got wide and narrow, and one can start to work out what type of tachycardia there is at play by using this. So this is a 55-year-old male who was in the ward. His only symptom of COVID was palpitations. And you can see on the left side, he's got atrial fibrillation with rapid ventricular response. And after cardioverting him electrically with synchronized cardioversion, he went back into sinus rhythm and went home the next day and was quite happy for his ability to feel good again. And that was really, he wasn't hypoxic. There was nothing else going on. This was his expression of COVID. Next one is the little scribbles in the top were me trying to put out the patient names, and some are done better than others. This is a gentleman who is 64 years old, came with seizures and COVID, and he has declared himself with an atrial flutter. So there's a 2-to-1 atrial flutter. So every second beat from the flutter is conducted, and he was also cardioverted with DC cardioversion, synchronized cardioversion, and has gone back into sinus rhythm. He's got quite a bit of atrial ectopy, and his heart is a bit irritable, but he's done quite well otherwise. This is a 48-year-old male. He was on high inotropes with sepsis and COVID, and this is a broad complex regular tachycardia, and the default diagnosis, until proven otherwise, has always got to be ventricular tachycardia. And so he was cardioverted electrically, and he has settled down since. So these patients can be challenging to, there was one time somebody said, if you don't know what it is, shock it until you do, which may be a little bit too aggressive at times, but one needs to think about unstable patients. You need to cardiovert them electrically if it's appropriate and if you're trained to do so. The ACLS guidelines are just as applicable here as they would be in any other setting. And then to maintain them back in that rhythm, once again, look for underlying precipitating factors such as electrolytes, but the sepsis over here, the inotropes are very high, etc. So that was all at play. Then just to say, then maintaining them back in that rhythm, sometimes you do need to use drugs such as amiodarone or others as required. Okay, so I'm going to go through in the last 15 minutes or so some cases, and what I'm seeking to do here, or aiming to do here, is to kind of just go through these cases. I think the cases stick in our minds in some ways, sometimes in a better way than huge amounts of data that may be thrown at us. And so just to go through the decision-making processes here and the thoughts that kind of cross mind. So case number one is Mr. H. He's a 48-year-old male with a full, oh, it says a full horse, but it's got a full house of risk factors in terms of obese, diabetes, hypertension, chronic kidney disease, not known cardiac previously. And he was chronic kidney disease on dialysis. He was transferred from another hospital with the concern of fulminant myocarditis. And that, as you may have picked up until this point in time, I've kind of left my the myocarditis in the back burner, and that's because, to be honest, personally, I haven't seen much of it. This description of fulminant myocarditis and COVID has not been something that I've seen. I have seen, as I say, raised cardiac markers. We haven't, to my knowledge, at Mill Park, given any patient the polygam, and we haven't, to this point. This patient was sent across with the concern of fulminant myocarditis for assessment for venous arterial ECMO. For those that are not familiar, ECMO allows you to take blood out of the body. In terms of VV ECMO, which is venous, it allows blood to come out of the body, be oxygenated outside of the body, put back into the venous system, and thereby oxygenate the blood when the lungs are unable to function. And VA ECMO is where there's the machine does both. It takes blood out, it oxygenates it, and then puts it into the arterial system to be able to assist the heart when the heart's failing. So they were concerned that this heart was failing with fulminant myocarditis and sent the patient across for assessment for VA ECMO. The patient had COVID and had now decompensated, had been given tocilizumab, which is an interleukin-6 inhibitor, and was on steroids, etc. The tropes were rising rapidly and were now 2,400, and the patient was very hemodynamically unstable. But importantly, the septic markers were rising. So the real question is, well, what's causing all of this, and does the patient have myocarditis? So on arrival, there was significant tachycardia, but the patient was on very high inotropes. The ECG did not show any ischemic changes and didn't show any changes in keeping with the pericarditis, but at that stage, that rate of ECG challenged to what you can see. The echo showed a very hyperdynamic heart, so there was no dilated pup heart. This was a very fast beating heart and didn't show any area of regional wall motion abnormality, although it can be challenging to see, as mentioned, once when the heart's going that fast, and no effusion around the heart. So the question is, well, what's the cause of the markedly elevated tropes? This was early on in COVID. It was one of the we've been seeing COVID patients since March, but this was kind of when we started to get going with the COVID now. And it was the first patient who had been sent across for VA ECMO. So definitely the patient didn't need VA ECMO. The question was, does the patient he has a lot of risk factors, does the patient have any coronary issues with tropes of 2,400? One needs to consider it. There's no indication over here there's a myocarditis per se, and there have been some description of myocarditis where there's actual inflammation and death of myocyte cells, of muscle cells within the heart. Weren't seeing anything keeping with that. Or is this all sepsis and supply-demand mismatch, et cetera, et cetera? So I took the patient through for an angiogram after team discussion. Once again, I'm very lucky to work in part of a team. These are some pictures. So on the left, you see the right coronary artery of this patient with absolutely no occlusive disease at all. There's beautiful flow all the way down the right heart. You can see the rate at which the patient's going, and this is not on fast forward. And then on the left, you can see the left coronary tree with the left main starting up at the top over here, and then following down into the left anterior descending and into the circumflex artery. So this patient really, there's more pictures, there we go. So left anterior descending artery, circumflex artery, and absolutely no occlusive disease. So this patient ended up being, the tropes came down once we got the inotropes weaned, once we got good antibiotics on board, once we really managed to try and work the patient into a more stable condition. Didn't require any VA ECMO. The heart is, in fact, I echoed him a few days ago, and the heart has been absolutely perfect. So this was really more about a raised trope of 2,400 from a supply-demand sepsis just the milieu and stress on the heart. Case number 2, if I've got time, yeah. So Mr. C was 67-year-old male. Risk factors for severe COVID are type 2 diabetes, and he was on oral medication, previous coronary disease with stents, now COVID with hypoxia on APRV ventilation. The ECG, it was asked to consult on the patient. The ECG showed atrial fibrillation with a slow ventricular rate, so no instability there, and a right bundle branch pattern. He had renal dysfunction with a creatinine of 268. CRP was up at 192. His PCT, however, wasn't. So there wasn't sepsis involved there, whereas with the patient before, the CRP and the PCT were up. We know that the CRP goes up with COVID, but the PCT doesn't tend to go up as much. So it's a much nicer marker to use to see if you've got sepsis on board as well. His PCT was flat. So now you've got a patient who's got renal dysfunction with high level of risk factors, previous stents, renal dysfunction that can cause troponins to go up, COVID that can cause troponin to go up. CRP is up, so we know that there's a chance that there's going to be cardiac involvement here. Troponins are 5,774. I'm uncomfortable with troponins above 800 in these patients. If they've renal dysfunction and sepsis, when they're above 700-800, I start to watch them extremely carefully and to repeat them more sooner than I would. I wouldn't leave the repeat troponin to the next morning. I would do it within 4 hours in these patients, 4 to 6 hours, and a D-dimer above 10. So does he maybe just have a PE? And that's why he's presenting with these high troponins, because troponins can also go up in PE. So when I did the echo in him, so I knew it wasn't sepsis, it was unlikely to be sepsis. There was inferior septal and lateral wall hyperkinesia. So I had wall motion abnormalities. So technically I had erased tropes, and I had changes on the echo showing that there was regional wall motion abnormality. So I could technically fulfill the diagnosis of a myocardial infarction in this case versus myocardial injury, which was in the first case. So non-ischemic, non-occlusive, this is, or nothing to do with the coronaries in the first place. This patient, I'm starting to think maybe this is coronaries, but I don't know if this wall motion abnormality is from the previous infarct and has been there for a long time, or if it's new. However, the wall wasn't thinned out, so I felt like this is probably not, it didn't help me definitively, but I felt there was a chance that this was new. Repeated the tropes and they were greater than 10,000. And I took the patient to angiography thereafter. This is on the left, the picture of the left coronary artery. I don't know if you can see my mouse moving, but firstly, you can see there's a stent in the, coming down over here. There's a stent there, and there's a branch that's missing here. There's a stent here. You may see the faint outline. There's meant to be a branch coming down here. What you then also see is all the way up this other side. This shouldn't be here. What this is flow to, as you see on this right side, the right coronary arteries. The right coronary artery is occluded, and I know that the right coronary artery is chronically occluded because it's got what we call retrograde flow, collateral flow from the left side of the heart. So I'm not worried about the right coronary artery, but I'm certainly very worried about this artery here, which seems to be a big territory. Put a wire down here, so I'm just showing you some of the coronary images for this patient. So you can see, once put a wire down, I've got a wire into this is the true circumflex branch, which is the big branch. And this is the obtuse marginal branch, is over here. You can see there's some thrombus sitting over here in the obtuse marginal branch as well. Let's put 2 wires down because I want to protect this branch. I don't want anything to happen to this main branch. Go up with a little angioplasty balloon over here to open up that vessel. And after going up with the balloon, then you come up with a stent and then have managed to restore flow down to that side of the heart. So this patient happened to have an MI, but he was ventilated, couldn't tell us about chest pain, and he underwent successful revascularization, but he couldn't tell us anything about chest pain. The pointers here was that I didn't see a markedly globally non-functional heart, so myocarditis was kind of not on the cards for me. The regional wall motion abnormality made me think that there's likely to be something more sinister in terms of coronary damage going on here. And the massive jump in tropes. is for me a real indicator that need to have a look and see what's going on over here. And that's why I say for myself, and I would strongly suggest monitoring, taking a baseline trope and seeing what it is. And if it is elevated, even if you do it every two days or so, unless it's really quite elevated, do it more frequently. But just 2 to 3 to 4 days, just keep an eye and see where that trope's going. And ECGs are also key. Case number 3, just in the last few minutes. So it's a Mrs. S. She's a 55-year-old female, comes in with hypertension, type 2 diabetes, morbid obesity, chronic kidney disease on dialysis, and previous coronary disease with stents. She was admitted for the plastic surgeons to do a graft or flap to her AV graft. She was on dialysis. She had a atrioventricular an arterial venous graft on her arm, and it was exposed. So they wanted to flap skin over and cover that. She was found to be COVID positive when she came through, but she was otherwise asymptomatic in terms of a COVID. She was chest pain free, but with her obesity, she showed signs of some right heart failure. And that was likely multifactorial. To consider obstructive sleep apnea in here was something that was probably causing that. So the physician who saw her did a baseline trope, which was 1,872 with a creatinine of 540. So now you've got a patient who's chest pain free with a whole host of risk factors, including previous coronary disease, who was admitted with a kind of happened to be COVID positive when admitted for plastic surgery, for a plastics procedure, but a very, very high trope. And ECG showed no acute ischemic changes, but once again, echo showed a preserved ejection fraction of 60%, but there was lateral. This was very, very localized regional wall motion abnormality. Old, new, for a variety of reasons, I felt this was new, and took her to the cath lab. This is her right coronary artery. You can see something missing here, which we're going to see in a better view over here. There's something missing here. It should be coming from here. Her left system had 2 stents in. You can actually see the stents over here, and those were non-occluded. I'm not showing the left system, but with her, then came down with a wire to try and open up this little area here, this vessel, followed it in with a balloon to dilate open the vessel. This is then after, so this is where it was occluded from, just beyond that side branch there. So all of this was occluded, and then bringing the stent in over here on this right. See the stent coming down, and then final picture. So that's the final picture, which is all the way from here beyond was occluded, and that's the entire base of the heart. That's the posterior descending artery. So once again, tricky presentation because she was chest pain free. She had a high troponin. She's got COVID. She's got renal dysfunction. She didn't have a component of sepsis on board. The kicker here was that she had a very regional wall motion abnormality. So last case. So, and just to say, so need to consider the mechanism for the presentation. So often the mechanism is multifactorial. Consider hemodynamics and fluid stasis, the inotrope use that you're using, specifically the type and the dose that you're using. Often these patients have been pushed onto a huge dose of inotropes, wean them. And then to think about fluids. ARDS patients tend not to like fluid. These patients seem not to like not having fluids. So they're slightly different kettle of fish. Sometimes within the right setting, you can give these patients fluids and you can settle them down like that. Myocardial injury, I've listed them there, physiological stress, cytokine storm, inotrope related, etc. And then myocardial injury versus myocardial ischemia, which was spoken about. Last case, and this is just something to illustrate COVID as a bystander. So Mrs. M is a 75-year-old female. She was transferred by heli, in fact, on Thursday from an outside center, and they were concerned regarding an acute inferior myocardial infarction. She was found to be COVID positive there in that hospital a few days before, and she presented generally feeling unwell and chest pain at times. this was the ECG they sent me, and they were concerned about an inferior MI, which I didn't feel as strongly about, though, the positive R waves in V1, V2 may be in keeping, but she does, that can also be explained otherwise. And there's no ST elevation inferiorly. What she definitively does have is non-conducted P waves. So you can see there's P waves that are totally not conducted. This was the ECG when she arrived at Mill Park emergency room. And clearly over here, one can see that this is a complete heart block with the ventricular escape rhythm of 40 over here. And she has had she took it to the cath lab to put in a temporary lead, and at the same time looked at the coronaries, which were clear, and she's had a dual chamber permanent pacemaker implanted on Friday. And the COVID is really, really a non-issue in her. So the COVID is a bystander. The reason why she went to the hospital when you question her is because of this heart block. She was hemodynamically stable with it. So take our messages just in the last minute or so. Don't forget about the non-COVID cardiac patient in the times of COVID. COVID is new, and large volume of good quality data is not available and is yet to come, and hopefully will come. So one needs to start to build their own frame of reference through their own experience. You need to consider the normal suspects in the abnormal settings. So an MI in the patient who's got COVID and this is precipitated likely this thrombotic state, the abnormal setting being COVID, all the risk factors were there, COVID's precipitated, and then to consider the abnormal suspects in a normal setting. So the other way around as well, the patient who's got cardiac disease is their only reason for presenting and is COVID positive. Tropes are a useful marker of cardiac involvement in COVID, and I strongly encourage their use. And any number of arrhythmias can occur, but one needs to have an approach to establishing what rhythm is occurring and know how to manage it. Consider the mechanisms at play for any problem presenting. Work systematically without jumping to conclusions. Oh, it must be myocarditis, it must be an MI. Have good reasons to hang your hat. I always used to say when teaching students that always think about, make your diagnosis as a GPS system. A GPS system has to have 2 satellites there before it can tell you your location. So always think about it in that way. Work as a team where possible. Often it's difficult if you're alone out there. Reach out for assistance whenever it's needed, as it's always available. There will always be someone on the other side of the phone if you call for help from our hospital, and I know from many other hospitals as well. If you call through to the control room, I'm sure they'll link you with someone. And then lastly, and I feel quite strongly about this, is some people say, well, why don't we do X, Y, or Z? And I think that the lack of evidence for definitive treatment in COVID is not a reason in any way to practice medicine in a way that we end up doing more harm than good. And I think that if we are going to try treatment modalities, they have to be done in a responsible way under specific trial conditions. And I believe that I am 1 or 2 minutes over time, but that's it. Thank you.
Perfect. Thanks so much, Nachie. We are a bit over time, but I'll still give everybody a chance if they want to ask any questions. Just as a reminder, you can either type your questions to the sidebar or raise your hand. I see there is a hand raised, so I'll unmute you. So your name's Nachie Tab, so I'm not sure what your actual name is. You should be able to unmute. You are unmuted on our side. Do you want to verbalize your question?
Yes, I would like to know if what is the place of Clexane thrombolysis with patients with elevated TROP-T without evidence of AMI?
So a thrombolysis in the, what is the role of Clexane and thrombolysis in patients with raised TROP-T? So, okay, if you're going to, I'm going to do the thrombolysis first before talking about the Clexane. So if you're going to give a patient thrombolysis, you need to give thrombolysis in the presence of an ST elevation MI, unless you're giving the thrombolysis for stroke or for pulmonary embolus. So if your patient has a raised troponin in addition to findings of an MI with chest pain, and then specifically in the setting of MI with a raised ST elevation, and you don't have access to a center within 2 hours that's going to be able to offer your patient primary PCI, primary intervention, then you need to consider using thrombolysis. And once again, you need to think about the bleeding versus versus using the drug versus not using the drug, and the insert of the package is fairly standard with that. But I wouldn't give it unless you were convinced that you had a patient who had MI, an ST elevation MI, and you weren't able to get them to a primary PCI center. So that would be then, if you're using it for pulmonary embolus, I think you probably want to, obviously if your patient's an extremist and they've got no output and you're pretty convinced that their main reason for this is pulmonary embolus, then you need to take a risk of doing that. But in a subacute pulmonary embolus or in a small pulmonary embolus, there's no role for thrombolysis for the most part, although there are exceptional circumstances where it may be required in specialist center. In terms of clexane is a key drug to be used. Any patient who is sick with COVID, in terms of especially those requiring ICU, and those patients who we discharge from ICU, we send home on anticoagulation as well, be it clexane or one of the NOACs, because especially when their D-dimers are raised, we are giving our patients clexane. We are doing a anti-10A level 3 hours after our third dose and kind of basing it off of that.
Perfect. Thanks, Nachie. I'm not sure if there's any other questions. I don't see any other hands raised or anything. So I think we'll probably call it there for tonight.
Great.
Thank you so much for the session. That was a really good session and something that we haven't really dealt with or touched at all in our series thus far. So it's actually a good perspective to get on a different side of COVID.
Thank you.
Cool. And so just as a reminder, our next session will be on Thursday night for this week. And then from next week on, it will revert back to the Monday, Wednesday setup. My apologies, there was a mix up and I had messed up the licenses. So some people can read once we hit the 100 mark. So I'm sorry if anybody that did struggle, but it won't be a problem going forward. Well, thank you all. Thank you again, Nachie, and hopefully we'll have you again soon.
Thank you. Looking forward. Keep well. Keep safe.
Cool.
Bye.